Hi, my name is Georgia Brown, and I am living with cystic fibrosis, and I also experience incontinence. I started having incontinence in my 20s, and I saw my gynecologist, and he told me that I couldn't be incontinent because I hadn't given birth. This was really troubling for me because I was leaking urine when I coughed and laughed, and it's embarrassing and it's something that you want to try to hide. So I did my best to manage the condition on my own. There's bulky pads, there's modifying your behavior, and really just getting depressed because you might not be able to do something because you fear being incontinent. Later in life, I ended up going to my CF clinic and I was doing my pulmonary function testing, and this was after driving an hour to my clinic. And I did my PTs and I leaked urine, and I was really embarrassed. I had to sit through my appointment, provider after provider, with wet pants, worrying that I smelled like urine. And I got in my car and I had to put a towel down so that I could drive an hour home. And I did this twice before I talked to somebody else with CF about this, and they advocated for me seeing a urogynecologist. So I went to the urogynecologist. We talked a little bit about my symptoms. I came back for another visit and I had a minor test done. I was diagnosed with stress and urinary incontinence, and I was given a pill. And this pill changed my life. And I know as CF patients, we take a lot of pills, and incontinence is a quality of life issue. It's not going to kill you. It just makes your life a little unpleasant. And that unpleasantness, I think, counts a lot when you're trying to live with a chronic disease. So this pill really helped me manage my incontinence, and I was able to go and do things. I didn't worry as much about laughing, crying, playing, running, and that made a difference in my mental health. When I brought up my incontinence to my CF provider, he was shocked. He had no idea that this was something that CF patients needed to worry about. And this has put it on his radar, where he now asks patients if they experience any type of incontinence, because you can have urinary, fecal, or flatulence incontinence. And I think it's very important to realize that this is a normal thing and it's an uncomfortable thing and it's a very uncomfortable conversation to have. And I've had it and I can tell you it is uncomfortable. At the same time, if you're experiencing anything like this, I would have the conversation. There's been very little research about CF incontinence done, but it can impact women up to 70% and 15% in men. And there have been patients as young as age 9 who have experienced incontinence because of the coughing and the stress that puts on the uh, urinary threshold, your pelvic threshold. So if you experience any issues, I highly, highly recommend that you talk to somebody about this problem. And I'm going to hand this over to a urogynecologist who's going to take us through some slides and really describe what urinary continence is and what can be done for it.
Thank you so much, Georgia. Thank you for sharing your story. And thank you for being brave enough to kind of tell all of us about how you got here today. I'm really honored to be here talking about urinary incontinence and agreeing that it has such a profound impact on people's physical well-being and their quality of life, and that there's so much we can do to help. So, yes, I'm Abby Shatkin-Margolis. I'm a urogynecologist at the University of California, San Francisco, and I'm here today to talk a little bit more about urinary incontinence. Starting kind of basic, urinary incontinence is the involuntary loss of urine. And if there's anything I can really drive home today, the real main takeaways today are that urinary incontinence affects a lot of people, and it has significant impact on people's quality of life. Why it occurs depends on the type of urinary incontinence we're talking about, and there are effective treatments. There is help. We can help patients regain their quality of life by improving their urinary incontinence. So if we look at adults in the United States, we know that 25 to 30% of adults experience urinary incontinence. That's more than 1 in 4. So this is significant. And if we look specifically at women, that goes up even higher. 30 to 50% of women in the United States experience urinary incontinence. And for men, that's 10 to 15% of men. And then if we look a little bit more at the older patients, patients 65 years and older, we exceed 50%. So more than half of women over the ages of 65 in the United States experience urinary incontinence. And for men, that number also goes up to 20 to 30% of men over the ages of 65. So this is quite significant. The prevalence is very high, and especially as the demographics in the United States and our older population continues to grow, we know that the number of people suffering from urinary incontinence is only going to increase. Not only is the prevalence significant, but the effect of urinary incontinence on people's quality of life is significant as well. We know that urinary incontinence can be tied to anxiety, depression, fear of leaving the house, decreased physical activity, and ability to maintain their daily activities. So this is really something that needs our attention. Not only can the impact on quality of life be a lot, but as also there's a significant impact on cost. The estimated total annual cost of urinary incontinence is between $65 and $76 billion. This includes direct medical costs like doctor's visits, medications, incontinence supplies, diagnostic tests, and surgery or procedural interventions. It also includes indirect costs like low productivity or work days missed due to incontinence, informal caregiving or nursing home placement. So this is, again, a very necessary area of focus. I'm going to talk about the two main types of urinary incontinence, which Georgia alluded to: urgency incontinence, urgency urinary incontinence, and stress urinary incontinence. Urgency urinary incontinence is involuntary loss of urine that happens with the sensation of a sudden or compelling desire to urinate or void. We think of that as like the key in the door sensation, or walking by the bathroom, or that maybe that very intense feeling of needing to urinate when you're washing the dishes. That's urgency urinary incontinence, as opposed to stress urinary incontinence, which is involuntary loss of urine that happens with physical movement or activity, such as coughing, sneezing, laughing, or exercise. So I'm going to talk a little bit about what treatment options there are for urgency urinary incontinence. And let me just start by saying there are many, and it can be confusing because there's so many options. But I want to shift that confusion to excitement, that there really are things we can do to help. Georgia alluded to behavioral changes and modifications that can be helpful. There are medications. There are neuromodulation treatments that focus on the nerve signaling to the bladder. And then there's bladder Botox procedures. So in terms of behavioral changes or fluid management that can help with urgency urinary incontinence, there are things like bladder training or urge suppression, where we slowly help your bladder learn to maintain control with larger volumes of urine. So we basically set up a routine for you where you incrementally increase the amount of time between visits to the bathroom, and we retrain that bladder muscle to withstand higher volumes of urine. This may be done in conjunction with pelvic floor muscle exercises, also thought of as Kegel exercises, or with assistance from a pelvic floor physical therapist. In terms of fluid management, we look at how much fluid somebody drinks in a 24-hour period. We look at what those different fluids are, whether or not some of them are considered bladder irritants, and we try to cut down on bladder irritants, such as basically anything that tastes good, coffee, soda, tea, alcohol. And then reducing how much fluids are ingested or drank between dinner and bedtime can reduce any urinary symptoms through the night. In terms of medication management for urgency incontinence, there's two main categories, anticholinergics and beta-3 adrenergics, and I've listed some common names here. The reason there's two groups is really just that anticholinergics stop bladder muscle contraction and beta-3 adrenergics promote bladder relaxation. But regardless of how they really work, their mechanisms, they both ultimately do the same thing for symptoms. They turn down that urgency intensity, providing more time to get to the bathroom when you feel the need to urinate. These are medications that you do need to take daily. The neuromodulation, or kind of working with the nerve signaling to help bladder function, comes in two forms. The first form is something we do in the office. It's called posterior tibial nerve stimulation, or PTNS, and it's a treatment we do once a week for 12 weeks. So it's 12 weekly sessions, and a session takes about 30 minutes. And we use a thin, kind of like an acupuncture needle right behind the ankle. And we stimulate a nerve in the leg called the posterior tibial nerve with a little external pulse generator, and that communicates to the nerve root that controls bladder function. So essentially, we are communicating with the bladder via nerves that travel through the leg. And our best research shows that women who complete 12 sessions have a 60 to 70% improvement in their symptoms. This has very little risk, very mild side effects, making it a very attractive option for many. The downside being mostly that it's time consuming and transportation to and from the office space. The other form of neuromodulation is actually a minor surgical procedure that we do in the operating room. It's called sacral neuromodulation, and we implant a pulse generator right underneath the skin in the lower back, and that's connected to an electrode that goes directly to the nerve root that controls bladder function. So again, we're communicating with the bladder through the nerves, but we're getting a little bit closer to the spinal cord. Our best data shows that 80% of patients who have this implant have a greater than 50% improvement in their symptoms. And then finally, bladder Botox, or onabotulinum toxin A. This is a procedure we do in the office. We use a small cystoscope or camera inside the bladder, and then we use a small needle through the camera and inject onabotulinum toxin A, or Botox, into the bladder muscle. You can see a picture there on the slide of a cartoon drawing of a clinician doing this procedure. Essentially, the Botox relaxes the bladder muscle again, so you're having fewer and less intense bladder spasms, bladder muscle spasms. The treatment lasts about 6 to 9 months, so typically patients are having this repeated once or twice a year. And our best data shows that it's 60 to 90% improvement in symptoms. So I'm going to shift gears now and talk about some treatment options for stress urinary incontinence. And again, I just want to emphasize that there are many treatments. We think about treatments in more non-surgical categories and surgical categories. So for non-surgical treatment of stress urinary incontinence, we think about strengthening the pelvic floor muscles, whether that's with your own self-directed pelvic floor muscle exercise routines, or if it's working with pelvic floor physical therapists. We know that strengthening the pelvic floor muscles provides more support to the urethra, and that's why it tremendously improves stress urinary incontinence. Other non-surgical treatment options for stress incontinence include incontinence devices, or essentially devices that sit in a woman inside the vagina to support the urethra, so that whenever there's a exertive activity, that urethra doesn't bounce as much and you don't leak urine. There are disposable over-the-counter products, and I've showed pictures here of two common ones. And then on the top is a picture of a pessary, an incontinence ring pessary, which is a longer lasting non-disposable device that sits in the vagina and can provide really wonderful symptom improvement, especially in patients who have predictable stress incontinence. For instance, I know when I go to this exercise class or I take this hike, I know I have stress incontinence, so I'll use the device then. And then we have this procedure called urethral bulking. This is a procedure that can be done in the office or in the operating room. Again, we use a cystoscope or a camera into the urethra, and we inject a material right into the lumen or the tunnel of the urethra to kind of plump it up, making it more narrow, so that when there is that exertion of coughing or laughing, there's less flow of urine and more resistance in the urethra. This procedure has been shown to improve stress incontinence by 60 to 70%. And then our gold standard surgical treatment is called the midurethral sling. This is an outpatient surgery that takes approximately 30 minutes, and we place a synthetic mesh sling under the urethra, kind of like a hammock, that provides a backboard or support to the urethra during any exertive exercises. A midurethral sling is about 85% symptom improvement, making it a very attractive option for many. And then more treatment-wise, from a community standpoint, we have researchers at UCSF who are focused on pelvic floor yoga and physical conditioning programs to help women with urinary incontinence. And they're finding that while there was no difference between yoga and a physical conditioning program between the two, that both groups actually got better. So we are recognizing more and more that there's benefits and non-medication, non-procedure, non-surgical treatments for women with urinary incontinence. And as I prepared for our meeting today, I was doing a little bit more research of urinary incontinence and how it affects patients with cystic fibrosis. And I was really surprised and blown away by the prevalence of urinary incontinence that's seen amongst the cystic fibrosis community, with estimates as high as 70%, as Georgia said. And that urinary incontinence can occur in adolescents with cystic fibrosis. So when Georgia was 20 and went and told her physician that she was experiencing that was real. Despite having never had been pregnant or had a delivery, those symptoms were real. And that we see that stress incontinence is the most dominant type of urinary incontinence amongst people with cystic fibrosis. And that makes sense with coughing and increased abdominal pressures and pressures persisting on the pelvic floor. It would make sense that stress incontinence be the most common type seen. And just a few online resources that I think are really awesome and accessible to everyone. We have the American Urogynecologic Society, AUGS, that has a platform called Voices for PFD. PFD stands for Pelvic Floor Disorders. And there's a slew of information, patients-facing information with wonderful figures and descriptions on all sorts of different pelvic floor disorders. And then also our International Urogynecological Association, IUGA, has similar wonderful aids as well. And I'll stop there. Thank you again. I'm from the Center of Urogynecology and Women's Pelvic Health at University of California, San Francisco. For any of our West Coast or California attendees, feel free to give our offices a call or place a self-referral and come see us so that we can help. The real take-home message being that urinary incontinence is very prevalent. It really affects people's quality of life. There are trained professionals like myself who have really extensive tools in their toolbox that want to help you. And please reach out. Thank you again, Georgia, for sharing your story and bringing attention to this important disease. I treat female patients. I can say that urinary incontinence does, in fact, affect both men and women. We do see it more prevalent amongst women, but we know that men with urinary incontinence or other pelvic floor disorders can often have the prostate involved in the etiology or pathophysiology of where the disease comes from. And therefore, I do really encourage any man suffering from urinary incontinence to seek urologic consult within your network.
I think it's really important to realize that it does impact males with CF. It's just probably a smaller percentage of the population, which is not to say it doesn't happen. Patients that I've talked to in different support groups and things, men tend to have more fecal incontinence. And as we know, there are a lot of GI problems associated with CF. And there's always that moment when you think, is it a shart or a fart? Been there, done that. So I can say that it does happen to a lot of CF patients. And that is another thing that happens that can be treated. There are ways that you can handle these problems with gas and other issues. Men do have problems, especially as they age, but it can happen at any age. So just remember, if you are leaking anything, it can be treated and it's worth having an uncomfortable conversation about.
Yeah, so the difference between a urogynecologist and a gynecologist is primarily to do with the type of training, the level of training, and area of focus. So, gynecologists complete a 4-year residency in obstetrics and gynecology and then go on to practice clinically from there. Urogynecologists can complete a 4-year residency in obstetrics and gynecology or a residency in urology, and then go on to do additional fellowship training for 2 to 3 years that primarily focuses on surgical and procedural and non-surgical management of pelvic floor disorders. So in terms of who the best person is to talk to if you're experiencing urinary incontinence, I always encourage people to first have a conversation with their primary care physician. Primary care physicians are very in tune with first line or behavioral changes and modifications to help with urinary incontinence. But certainly, if that's not improving your symptoms, that's when I would recommend talking to a urogynecologist to kind of talk about next steps in treatment.
And building on that, I think sometimes you have a affinity to see somebody of the same sex. So I don't want to count out urologists. They are a great source of information for males with CF. And I do think males with CF need a relationship with a urologist, much like women do with their gynecologist, because there are different issues that males can face in addition to incontinence over their lifespan. And it is important to have a relationship that you can talk to somebody about the problems that you might be experiencing.
Yeah, I couldn't agree more with you, Georgia. And whether or not it's related to gender or practice style or whatever, it's so important that you feel a connection and a good rapport with your physician because often it can take multiple visits or trials of different treatment options until you really feel like you're meeting your goals. And you want to have that um, availability and approachability with your clinician to continue different options.
When you're talking to your provider about incontinence, whether it's fecal, flatulence, or urinary, it's hard. I'm not gonna lie. It's not something you want to admit to. There is a lot of stigma associated with incontinence. I've done something wrong. There's something wrong with me. And I think once you get past that, you can simply say, I think I'm having a problem. And sometimes when I cough, I leak urine. Or when I do my PFTs, I leak urine. Or even if I do my vest or breathing treatments and I'm coughing, I leak urine. Incontinence is a word with a negative connotation. So maybe just speaking about leaking is another issue that you can have with your doctor. I highly, highly recommend you have this conversation, but it does take guts to do it. And if you want to rely on me or other patients, we have talked to their doctors about them. That's how they have treatments. That's how they have products to help. And you're just one of the few that unfortunately are experiencing this problem. And pads are bulky. If you can take a pill, I highly recommend doing a pill over the bulky pads. They're uncomfortable. You feel uncomfortable. You worry about smelling like urine. And it's not fun. And it can really reduce your outside activity outside of your home. And just say it. It's hard, but they're not going to judge you. You will not be judged. You will be treated. And that's the difference.
Yeah, I think I agree with everything you're saying, and those are really useful tips to normalize the conversation. I think I have the perspective from a urogynecology clinic, which is this is all we talk about with every patient. So if that feels like a more welcoming environment, please do see your local urogynecologist because this is, again, these are the conditions we are helping people with every single visit.
I hope people take away the normalcy that we are making incontinence be. It's normal. It happens, especially as you age. But if you're young and you're experiencing this, and I've talked to other patients who have, they sent me a private message. They didn't want to say it in front of a group or in front of anybody else, but they say, thank you for talking about this. Find somebody that you trust, that you want to talk to about this. If it's a urologist or you're a gynecologist, it's your PCP, your CF clinic, your respiratory therapist, one person that you trust or don't trust but don't know. Maybe you don't want to talk to your CF clinic. Maybe you just want to go to somebody different. That's okay too. The point that I'd like you to take away from this is there's treatments available. Please don't suffer in silence like I did.
Yeah, I would just echo what Georgia is saying. I think it's just so important to take away um, that treatments exist, the treatments work. And, while there's been a lot of research and we've come leaps and bounds in terms of adding to people's quantity of life, I'm not sure we've maintained the same progression for helping people's quality of life. And that's what's so important. And I think the other really amazing takeaway is just the power of speaking up and Georgia's willingness to share her story and reach out to uh, the CF Research Institute and create this platform. And the more we're able to share, the more research, the more resource, the more we can improve uh, um, the focus on urinary incontinence.